What is cooling and how does it work?
Oh, wow. Cooling is amazing. I like cooling because a lot of times we can see a baby that was really injured at birth and then do really, really well. Basically, it's a baby that's had some type of hypoxic injury. They have to meet a certain weight and gestational age criteria. So we're not gonna cool a preterm baby at all. Um, let's say you had a mom and she had some type of event that caused a hypoxic injury, a cord prolapse, a placental abruption, a uterine rupture, um, meconium aspiration. Like there's anything that could cause a hypoxic event. Those babies come out. We do what we call a SARNAT score, where we rate them based on criteria of alertness. We look at their pH levels, we look at their lactate levels in their cord blood, and then their blood substantial subsequently after that. And we have up to 6 hours to decide whether or not we want to cool that baby. Some babies are like, should we cool? Should we not cool? Like those are the harder ones versus the ones that are like, yes, this baby needs to be cooled because you have that certain window and like you'd hate to miss that window and go, oh man, it's 7 hours and now we're having seizures and we've missed the window. Right. So a lot of times the attendings may go talk to the parents and go, it's a SARNAT a 1, think your baby could benefit, the risks to benefit outweighs, or the benefit outweighs the risks. So we're going to go ahead and proceed with cooling, and then we'll talk to them about that. So the cooling process is basically the first thing we do is we get a full set of labs, put an EEG on the kid, a video EEG, which has all of the monitors, and we put them on a cooling blanket. The blanket usually consists of just water that's maintained by a machine that goes into this blanket underneath the baby, and we try to wrap as much surface area as we can. We have a temperature probe in the baby, whether it be into the esophagus or rectal. We use esophageal probes where I cool. And actually, now, if that baby is stable enough, we can allow parents to hold in that cooling blanket. It just depends. It depends on the nurse's comfortability with it and how sick the baby is. If this baby is super, super sick and is intubated and has lots of drips and pressors, that baby's probably not going to get held, right? But if you have a baby that was maybe like one of those SARNAT ones, not quite sure, still able to breathe on their own, doesn't need blood pressure medication or anything like that, those parents might be able to hold. So cooling lasts for 72 hours. And then we start the warming process up after 72 hours. During that whole time, they're being watched for seizures. If there is seizures, we'll give them medications for those seizures based on what the neurology says. And here's the funny thing with babies and seizures, like you can't always tell that they're having a seizure. And that's why we put the EEG on. Or sometimes we think that baby's seizing, like that activity looks really weird. And then the EEG goes, no, that wasn't a seizure. So they're really, really hard to identify an infant without the brain machine. So we use a full montage on all of our neuro kids. So after 72 hours, then we start the gradual warming process. It takes anywhere from 6 to 8 hours for that baby to get back to normal body temperature. There's always a head ultrasound at the beginning as well. And then we'll do a head ultrasound at the end. And then 7 to 10 days post cooling, from the time it started, they'll have an MRI, MRS. And that goes in and tells us and shows if there was any brain damage that was sustained during that hypoxic injury and where we can probably may go from there. So I've seen kids just do amazing things. They took a big hit, we get them cooled, we slowed their metabolic rate, the brain was able to do a lot of healing, and they do really, really well. So that's the
Oh,
basics of cooling.
no, that's cool. I know there's a lot, like people ask about it all the time, and I'm like, I don't know. Like we actually hear about cooling a lot more than you would think. And it's like,
Yeah.
I
Well, we're
can't.
monitoring labs the entire time. We're monitoring coagulations. We're looking at all the lactates. We're looking for, we're pulling labs. I swear we almost like sanguinate these kids because we're pulling. So those kids get central lines automatically, and they also get arterial lines. where we're constantly, continuously monitoring blood pressures, and we're able to take away blood without having to poke them. So we want to try and keep that. We want to keep the stimulation down as much as possible during the cooling process. So we get those lines in so that we're not constantly having to go in and do that all the time. So.
Can you discuss a little bit about what, like just dive a little deeper into what you're looking at for the lab work while cooling is happening? Because exactly what you were saying, I had my son's, my chart, his notifications linked to my phone, and the whole time he was cooling, I swear I had lab work alerts every,
Every
thing
12
that
to
just
24 hours, we were pulling some kind of lab off that kid. Yeah. Yeah.
So that was so incredible. And I do remember it seeing all of the ones you just sort of mentioned with the blood gases and pH. And it's, for a layperson, a lot of, I did have great people at there, both neonatologists, nurses, and others who explained to the best of their ability what, they were looking for them. But I just wondered if you could kind of elaborate a little bit about the type of lab work you're typically doing during cooling and what you're kind of looking for.
So we're looking at blood gases. We want to know how the baby is ventilating and respirating. I'm going to go basic. Okay. I'm not going to go into
Yeah.
details and tell you
Oh
about
yeah, for sure.
We're looking for electrolyte issues. We want to make sure that potassium, magnesium, go on with the kidneys, a hit in the kidneys. We're looking at your bun and creatinine. We're looking at your levels. We're looking at how your liver is processing everything. Do we take a hit to the gut? We're going to see all of that in those labs. We're also looking at coags, PT, PTT. Is this baby at risk of bleeding because we're cooling the body and things like that? We're looking for infection, right? We're always looking for infection in the hospital. So all of those things get pulled, and we just go over them. And then, if your electrolytes are off, I might write another TPN. If your ventilation and oxygenation isn't right, we're going to change ventilators. We might change settings on the ventilator, things like that. So we're always treating not just the patient, but we're treating labs. So especially in a cooling patient, because they're usually asleep. So with cooling, you also want to make sure you're not shivering, so they're sedated, right? If you have a baby that's cooling and he's actively shivering, you're countering the active cooling process to slow everything down. So then we sedate them so we don't see them shivering. And if they're sedated, then we got to make sure that they're ventilating correctly, because when you give a lot of medications to sedate, then you don't breathe. So we got to make sure it's all these things that all kind of go together.
As a parent, that was very sad to see. My son he was shivering, and then they did sedate him, and that was very sad for me. I have to say, like, one of those that was very difficult.
Yeah, I hate it when I can't get on top of that. It breaks my heart.
Yeah.
It breaks my heart. And I will just, if my kid's intubated, we call it PRN them, give them more, give them more. But only if they're room air and breathing, there's only so much we can do, because we don't want to stop them from breathing.
Right. Yeah. It was a little bit funny because he was so sedated that when he woke up, the first 24 to 48 hours after rewarming, I actually thought he was just this very laid back baby. I was like, he is just very peaceful. He just kind of looks up at me, and he was not a chill baby at all. He was a very high strung baby. He just had been very sedated for several, so right. I remember being kind of tricked though, and thinking I think that he's actually this very sweet little calm baby, but he was not. Yeah. He was just had morphine,
Yeah.
From what I heard was that shivering babies is they're having a seizure, and that babies don't shiver.
Right. Babies generally don't shiver, even when they get cold, but we're putting them really, really into a place where it can be catastrophically cold. I mean, we're constantly monitoring that. So we do see some shivering. And like I said, we sedate to counteract the shiver, because the shivering increases the metabolic rate of the baby, but we're trying to slow that down to promote healing in the brain. So that's why we sedate when they're cooling. And if you see a lot of shivering, we're going to sedate even more. So, and then we do have an EEG, a video EEG on the whole time. So we can tell if it's a seizure versus shivering. So we can monitor the differences there.
What's the care for after cooling?
Oh, okay. So the follow-up after discharge?
Okay. Yeah, the follow-up after they basically kind of, I guess, I think it was after they're done cooling and they come, I don't want to say back to normal, but you know what I mean?
Okay, so once they're rewarmed. Yeah. So Okay, so we've gone through the 72-hour cooling and we've rewarmed the baby, and then the process to get them out the door and discharged. So we bring them up to temperature, we make sure their vital signs are stable, and we generally will start feeding. Feeding can be a critical time too, because cooling shuts everything down. So that means the gut was down, everything was down. So we start very, very slowly, and we start with feeding. If they're on any respiratory support, we wean that as well. So if they were intubated and sedated, we'll lower the sedation, we'll work our way so that they're no longer on a ventilator. Maybe they go to high flow or CPAP and high flow, and then wean to a nasal cannula. Some kids, never have to be intubated while they're cooled. It depends on the baby. So we start pulling those things back, like things start coming off. We're not drawing labs anymore, so we remove their A lines. If they had a Foley catheter, we DC the Foley catheter. So you start doing these things once they're warm. And probably the longest thing after cooling is getting up to full feeds, because we start really, really slow. We trickle in. We don't necessarily start bottle feeding right away unless they're actively showing that they're hungry and queuing. But then we have to get them to full feeds before they can go home. And then a lot of times we keep them inpatient for that follow-up MRI, MRS, and that happens 7 to 10 days post-cooling. So they're going to be there at least another week. I think the fastest I've seen a kid go home on cooling is maybe a 10, 15 day admission, but sometimes it's even longer. It just depends on the kid, and feeding and gaining weight and not having any vents is what gets them home. So, and then that follow-up MRI. And then once they're discharged, they're followed by high risk clinic. They go in at scheduled times. We want to make sure that their developing fully, and if they're seeing deficits, to get them the interventions that they need. So yeah, there is long-term follow-up with cooling as well. And data. We're constantly collecting data. I don't know if any of it's being published, but I did talk to one of the high-risk physical therapists recently, and she says we are collecting the data. No one's looking at it, but we have the data.